Hello, everyone. I am Julie Gayle. I'm the coordinator of the Women's Health Nurse Practitioner Program at Northwestern. And I have with me today one of my students, Olivia Chappelle, who will be graduating in May. And we are going to talk about sexually transmitted infections. And it's just going to be more of like a discussion, we're calling it a faculty and student podcast. But we appreciate you joining us, and we're going to get started. So we're going to discuss the different types of sexually transmitted infections, but Olivia is going to present some cases with us, some patient cases, so we can go through them. But this is just a list of your bacterial infections, viral, and parasitic infections. Fire away, Olivia, about our first case study.
All right, our first case study is Miss Katie. She's a 23-year-old female with complaints of discharge and dysuria.
So differential diagnoses for her.
We have chlamydia, gonorrhea, trichomonas, and bacterial vaginosis. So even though bacterial vaginosis isn't an STD, it's something that we should consider anytime a patient complains of discharge.
So in talking about chlamydia first, what are some risk factors that may make Katie, that's her name, right?
Right.
That would make her susceptible?
Well, she's a female. She's less than age 25. She
And
just complaining
definitely.
of she's complaining of discharge, so that's something that we always want to consider.
And then just looking at the slide, because we don't want to read the whole slide, but just kind of touch on some important things. Like Olivia said, she's female and she's under the age of 25. And that is recommended by the CDC that women 25 and under be screened for chlamydia and gonorrhea yearly or more often if they're at risk. So you mentioned in the slide that it's more prevalent in women.
Mm-hmm.
Um,
And that's because,
go ahead, I'm sorry.
well, it's just the vaginal lining is thinner than the skin on the penis, so it's more susceptible to infections of bacteria and viruses. And also the environment, it's more moist, so it's a great environment for the growth of bacteria.
Yes, and so any you want to inquire about what kind of sex your patients are having, because you're right, if it's if there's more mucous membranes exposed, like in the vagina or the rectum, then they are going to be more likely to acquire a sexually transmitted infection. So what would be some symptoms if, well, Katie already has vaginal discharge and dysuria. So you mentioned that here. What would be some other symptoms?
They might have abnormal bleeding, so bleeding in between periods or after intercourse. They might have painless genital ulcers. They may have some vaginal itching, irritation. A lot of times, though, the patients are asymptomatic, so that's why it's important to screen and test them, because it can lead to worsening conditions such as pelvic inflammatory disease.
Good. And then I did want to mention too that the chlamydia, well, you mentioned this actually, the postcoital or the intramenstrual bleeding. For sure, if you have a woman coming in having some spotting in between cycles, then infection should definitely be on your radar. Let's see. I'm sorry, I'm having difficulties here. So tell us about the testing and treatment of chlamydia.
So for testing, we can test either through the urine or through swabs. And for treatment, right now, the first line would be doxycycline, 100 milligrams by mouth twice a day for 7 days. And then for pregnant women, it is amoxicillin 500 milligrams 3 times a day for 7 days.
Yeah, and this was actually a change from the previous guidelines. It was the azithromycin 1 gram PO as your first line, but in the 2021 they did change it to doxycycline is going to be your first line, except for, like you mentioned, the pregnant women. And these are some of the images that Olivia found for us. So you can see the cervicitis, conjunctivitis, a penile infection, and then, of course, in the throat. And they are encouraging some site-specific testing. So you can screen for chlamydia and gonorrhea in the throat, rectum, vagina, or urine. Oh, tell us about your fun facts there.
I
It says that
think we're losing connection.
oh no. Can you see the screen?
Dr. Gayle, can you hear me?
I can hear you.
Oh, I got you.
Can I come
Yeah,
back?
I think we're having some connection problems, but we're back.
So I was saying you
So
had a
yes, we have
few.
some fun facts about gonorrhea.
Yes, tell us about them.
Oh, no. Okay, can you hear me? Okay, sorry. So, fun facts is that gonorrhea was actually mentioned in the Bible, and also gonorrhea is known as the clap, which I did not know that. I always had thought that the clap was chlamydia, but it is gonorrhea, and it comes from the Les Clapiers, which are an ancient Parisian red light district.
Interesting. All right. So tell us a little bit about gonorrhea, or maybe what would be some symptoms of gonorrhea.
So again, it may the patient might be asymptomatic, but if not, a lot of the symptoms are kind of the same as chlamydia. They will have discharge, irritation, itching, um, pelvic pain, irregular bleeding. So well, you have to test together for chlamydia and gonorrhea.
Yes, I don't think we mentioned that. Oh, it's right here. So the nucleic acid amplification test can be ordered on urine or any of the endocervical, urethral, or rectal swabs to screen for chlamydia or gonorrhea. And then tell us about the treatment for gonorrhea.
So the treatment for gonorrhea is a little tricky because this bacteria is becoming more and more resistant to antibiotic therapy. So right now, the best treatment is Rocephin or ceftriaxone, 500 milligrams IM once. That's for patients weighing less than 150 kilograms, and it's 1 gram for those weighing greater than 150 kilograms. It is becoming more and more resistant to cephalosporins, so previously, it was recommended to do doxycycline and azithromycin for these infections, but now we're seeing an increase in resistance against azithromycin. So we're trying to, stick to this ceftriaxone. If you can't exclude the diagnosis of chlamydia, then you also treat with doxycycline 100 milligrams by mouth twice a day for 7 days.
And it's kind of this is kind of a scary bacteria to me because it's become like all the classes of antibiotics have become resistant to it. So we're
Right.
kind of like on the very last class of antibiotics. So the cephalosporins is really currently the only bacteria the only antibiotic that's effective for treating it.
Okay.
And again, you can have the site-specific testing of the throat. And then when would you, if Katie did test positive for chlamydia and gonorrhea and you treated her, when would you want her to come back? Would you want her to get a test of cure?
Yes, 3 months after treatment.
Good. Yeah, so, and then we've kind of already mentioned this, but with chlamydia and gonorrhea, you cannot have symptoms, which can impact or lead to pelvic inflammatory and impact fertility in the future. So that's why it's important to be screened and be sure that you are adequately treated for it. And here's some nice pictures. So another differential for Katie could be the trichomonas. This is a protozoan infection, very common. And I agree with the statistic that is most prevalent in women ages 40 to 49. That seems to be where we see it the most in clinic.
Which is really interesting because it's so different from the prevalent age group of gonorrhea and chlamydia.
Yeah, I do find though too, this one's kind of like, you can have patients that have no symptoms with trichomonas, and then you can have some that have like a lot of these symptoms that are mentioned here on this slide. And you can have, it's one of those infections that can kind of hide itself or lay dormant and then show up. It's been found in women like 20 years after no sex in nursing homes, that just it wasn't like where they had like acute inflammation right then and there. It just kind of was a chronic thing. So the testing for trichomonas, you can use the NATS testing, or you can just take a sample of the discharge, look under the microscope, and you will see these little creatures that are actually in the background of Olivia's slide. And this treatment also changed with the new guidelines. Tell them about that, Olivia.
So now it's I'm gonna say it wrong. Metronidazole
That is
or
all.
Flagyl, yeah, 500 milligrams twice a day for 7 days, and it used to be. And correct me if I'm wrong. If it was 2 grams, one.
Mm-hmm.
Okay,
It was.
and and that's what it
Which
is for
that's
men
still
now.
recommended. Which that's still recommended with men, but for women, they're recommending the 7-day course.
Mhm.
And we didn't really, I've mentioned people being asymptomatic, but other than the discharge, that frothy discharge that you see in the picture here around the cervix, they can have some petechiae on the cervix, and that looks like the strawberry cervix. And remember, you don't have to see these things. You can, but you don't have to. Like, what's going to make the diagnosis is seeing the trichomonas either under the microscope or in a positive NAT testing. So while the bacterial vaginosis is not a STD, it should be mentioned and be on your radar in the workup of a patient like Katie who presents with discharge. Tell us about BV, Olivia.
Okay, so as we mentioned, it's not sexually transmitted. It occurs from an imbalance of the naturally occurring vaginal flora and a decline in lactobacilli. So it's just an overgrowth of bacteria, pretty much. It's most prevalent in African American females, and it affects 30% of females ages 14 to 49.
And the typical symptoms are going to be that thin white to gray vaginal discharge, and that fishy odor. So in making the diagnosis, you may hear the Ansell's criteria, where you'd want 3 of the following criteria that are listed here on the slides, either the clue cells seen on the microscope when you collect a wet mount, the pH greater than 4.5, a whiff test, which could, sometimes you don't need to even add the KOH, but and this can be diagnosed with microscopy or the NAT cultures, and the treatment is the same for women with trichomonas. So it's the 7-day course of flagyl or metronidazole, 500 milligrams twice a day. There are some creams available. They are a little bit pricier. I don't know. Have you dealt with those in your in clinic with the creams? Do you ever do the creams?
No, we haven't.
I feel
We
like it's
sometimes do clindamycin PO, but I've never had the creams.
I think they're a little bit more expensive, but they are available. And here's some pictures of the discharge. You can see it's kind of adherent to the walls. It's kind of that thick, well, kind of that sticky discharge. So with Katie and her discharge, we talked about chlamydia, gonorrhea, trichomonas, and bacterial vaginosis as being possible causes of her discharge. Would it talk about this slide, Olivia, as far as what we would want to tell her if we were, let's say, if we were treating her for chlamydia or gonorrhea, what is some counseling to be sure to include for Katie?
We definitely want her to be compliant with her medication, and also make sure that she informs her partner that they need to be treated also, and then they need to abstain from sex for 7 days following treatment, whether that's a single dose therapy or the 7-day regimen. They need to wait for 7 days and wait for resolution of symptoms.
Yeah, I typically tell patients while they're like, consider yourself still contagious until you finish the antibiotics. And then, of course, so your partner does too. But you mentioned consider PrEP, which is HIV preventative medications for anorectal infections. And that's true. And it's even a vaginal infections. I would say if you had someone that is having high risk sex, then definitely consider initiating PrEP for them. Anything else to add about the discharge or Katie's situation? Definitely offer other STD testing, because when there's one STD, there could be another. Definitely offer HIV testing, because in the presence of one STD, it can increase your risk for acquiring HIV. You mentioned treating the partners, abstaining from sex until all the treatment is completed. And then test of cure is typically 1 to 3 months, would you say? Yeah, for all of them. Of course, if they're pregnant, you would want to try to do a test of cure, in that final, I would say, 4 weeks, leading up to delivery. So we have Matt. Tell us about Matt.
Okay, Matt is 27 years old. He is a male who has sex with males, and he is complaining of a genital lesion. So our
Go ahead. I'm sorry.
our differential diagnosis is syphilis HSV or genital herpes, and HPV genital warts.
And just to note, like you would further inquire, is this a painful lesion? Is it an ulcerated lesion? Because with syphilis, it's often the painless ulcerated lesions, whereas with genital herpes, it's going to be painful ulcerated lesions. Did I say that right?
Mhm.
So in starting with syphilis as a differential diagnosis for Matt, tell us about syphilis, how it's passed from one person to another.
So it's usually passed between mucous membranes. It can be passed through blood or skin to skin contact, but it's less likely. It's mostly transmitted through intercourse or sexual activity, so oral or rectal, genital. That's usually how it's passed. Um, and then they'll usually develop a canker at the site of the of infection.
Yes, and that's why you can, whereas you don't often see the canker just because it comes and goes so quickly and it's painless, and a lot of times they didn't even know that they had that. If a patient's going to present with symptoms, it's going to typically be in your secondary stage, which is going to be more of a systemic reaction like a rash. And you have on here that syphilis is commonly seen with HIV, and that's true. And I want to add to that that if they test, of course, if you have someone who tests positive for syphilis, you're definitely going to want to test them for HIV. But if they test negative, and this is a patient who's possibly not responding to treatment, then you would be sure to test for HIV. To tell us about this slide, it's got the different categories, the different stages. Primary, which is when the canker would be present. Secondary, which I just mentioned, would be more systemic symptoms. So like a rash, whether it be on the palms of the hands, bottom of the feet, the trunk. You can have condyloma lata, which are actually warts, mucus patches, and then latent is basically no symptoms. They just test positive. And then tertiary, we don't often see because it's going to be, you're going to have it so long that it's going to start impacting the organs. And you just don't see this as much because of the wide use of penicillin. And then anything about congenital syphilis, Olivia, this is actually not terribly rare. I'm sure you come across it in practice.
Yeah, have to be careful. But the infant or the fetus can be infected, so it can be transplacentally or through contact with lesions during birth. And so then the baby might have symptoms such as seizures, nasal cartilage destruction, bowing of the tibia, bulging fontanelles.
And we do screen, we screen pregnant women initially for syphilis when they enter prenatal care, and then again at 36 weeks typically, and then when they're admitted to the hospital, they will typically screen them. So the testing for syphilis, there's the non-treponal testing, which is the RPR or BDRL. And that's kind of that was a traditional algorithm that we use. But, that is really non specific testing because you can have a lot of false positives with the non-treponal testing. There's other things that can cause it to be positive, with pregnancy being one of them. And then your treponema testing is actually, you know, the antibody of the T. pallidum. So, which is the organism that causes syphilis. So now, whether than, you know, it used to be you test the RPR, VDRL. If it's positive, then they would do a treponema test to confirm it. And now they have the reverse algorithms where they're actually testing the more, you know, the antibody first. And then if that's positive, they'll test the non-treponema, and then it'll generate a titer like 1 in 4, 1 in 32. The problem with that is going to be if you've ever had syphilis, you're going to have a positive IgG or positive treponema test. That will always be positive. Whereas your non-treponema test, you know, maybe stay positive for a year, sometimes 2 years. But it can be kind of confusing sometimes. But what, as far as your non-treponema testing, like your RPR or VDRL, is going to be how you monitor treatment. What else can we say about this? The treatment. The treatment is going to be the penicillin G or bacillin, and it is going to be, you either get the 2.4 milliunits IM once, or you get it over, you know, you get it once for 3 weeks. And the length of the treatment is going to be dependent upon the stage, if you can stage them in primary or secondary, or they've had it less than a year, then you can just treat with the 2.4 milliunits IM once. If it's someone that you don't know how long they've had it, like maybe they've never been tested for it and all of a sudden they test positive for it, and you're looking at, they're considered latent because they have no symptoms, but they're considered of unknown duration because you have no idea how long they've had it. So again, you're looking at 2.4 milliunits IM for 3 weeks. For someone who's allergic to penicillin, doxycycline, whether you do it 2 weeks or 4 weeks, that's going to depend on, again, how long they've had it or if you can stage them. Tell them about the pregnancy specific treating.
So in pregnancy, the patient has to be treated with penicillin. So even if they're allergic to it, they'll have to be desensitized and then still be treated with penicillin.
Correct. And the same goes for if they develop a, like if it invades the central nervous system and they have any kind of like ocular syphilis or possible neurosyphilis, then you're looking at definitely using penicillin. And it's important to mention with syphilis that it can invade the central nervous system at any point. I feel like people tend to think neurosyphilis is equivalent to tertiary syphilis, which you don't see as much, but that's not true. It can, you know, like I said, get into the CNS at any point. And I've actually had a few cases of ocular syphilis that the patient was going to the eye doctor and giving him these drops, and he supposedly had some kind of rare autoimmune disease. Is what the eye doctor was telling him, and it turned out to be syphilis.
Oh.
So it's not uncommon to see that. So that should be on your radar for sure. And also, there's a reaction that you want to counsel the patient when you administer treatment for syphilis, and it's more common in early syphilis, like meaning they contracted it, you know, in less than a year, is the Jerick-Harsheimer reaction. It's basically their body's reaction to the spirochetes being killed, or, you know, the death of the spirochete. So it's a systemic reaction that the patient may have. They may have feel like they have the flu. They may start nausea and vomiting, shaking, but it's usually very short-lived, and it's usually within the first 24 hours of treatment. So I tend to tell patients, if this happens, if you wake up in the morning, that might be what's going on, and it does go away pretty quick. For pregnant women, this can manifest as preterm labor or labor. So it's important to be alert to that if you're treating any pregnant women. And these are some images. You've got the canker here. You can see it's like just a little ulcerated lesion. And again, it's not going to be painful typically with syphilis. And then you've got the maculopapular rash. You can see it on the hands and the feet here, on the trunk, and then the mucus patches here on the tongue. So move into HSV or herpes. So if Matt's complaining of a painful genital lesion, you would definitely consider HIV or HSV. There's two types of HSV, type 1 and type 2, and type 2 is most commonly associated with genital herpes. However, there are cases where there's type 1 in the genital area. Tell us about this, Olivia, because I feel like I'm talking too much.
Oh, so yeah, like you said, you can have HSV1 in the genital area and HSV2 in the oral area, even though HSV1 is more commonly associated with oral ulcers, and HSV2 is more commonly associated with genital ulcers, but they can be transmitted to both areas. It's more prevalent in women than men. It's actually very common. 1/3 of the world's population has experienced symptomatic HSV1 outbreaks. And actually, most people don't even know that they have it. So 85 to 90% of the cases are asymptomatic. So a lot of people, there's a stigma around it, but people don't realize that it's actually very common. It's so common the CDC recommends against testing, doing serologic testing for it.
Yeah, so this is kind of one of those, we used to think that if you had a lesion was really the only time it could be passed, but that's not true. And most people, like you said, don't have symptoms. So they look at maybe only 10% of the population that has HSV even having symptoms, but you can pass it without symptoms, obviously. If you can be shedding the virus without having symptoms. The culture, I think do we talk about that in the next one, the testing?
Yeah.
Probably. Okay. Well, we can talk about the symptoms first real quick. Uh-oh. Did I lose the thing? No.
Yep, we're on symptoms.
Okay. So typically the most severe symptoms are if you're gonna have symptoms, right? Because most of the time you don't. But if you do, the most severe symptoms you would have are typically going to be with a primary infection, meaning you just contracted the virus. Also, you can have the prodromal symptoms leading up to this kind of like flu-like symptoms, kind of body aches, headaches. And then, of course, you can have some lymphadenopathy, like inguinal lymphadenopathy. And then, of course, the painful ulcers. Anything else on there? Definitely the dysuria. So the testing, so of course the PCR culture is going to be ideal, but that's, they have to have a symptom, right, for you to do a culture. And they actually have to be, the lesion itself kind of goes through stages where it's ulcerated and then it kind of crusts over a little bit. So it's kind of got to be in that stage where you can get some of that serous fluid onto the culture, which, typically involves you having to unroof the lesion to get the fluid, which is typically pretty painful because these are pretty painful lesions. And then even then, typically the culture, well, the PCR would be pretty accurate. But again, it's going to depend on, where they are in the stage. And then, I'm sorry, I got distracted. So ideally is just to use the serology, right? Which is going to test for IgG and IgM for HSV.
But we don't typically do routine testing for asymptomatic patients.
Right. And then again, if you've got someone who comes in with a primary infection, your serology might not be as helpful, right? Because they're probably going to be negative. It can take them anywhere from 2 weeks to 3 months to develop an antibody. So it's important to keep that in mind that, if you suspect that it's primary, just to have the patient retest. But of course, in the meantime, it doesn't hurt to do a course of the valcyclovir or Valtrex, which in this slide, you do talk about the treatment. And you have pretty much the most common antivirals that are used, the acyclovir, famciclovir, and valcyclovir. And they're all equally really effective. I think you end up having to take a little bit more pills, the acyclovir, compared to the valcyclovir or Valtrex. And as far as treating, so typically if you first diagnose a patient with this, when they first contract it, the first 6 months is when they're going to have the most viral shedding. So in addition to just doing an acute treatment of the antivirals, it's usually a good idea to just move them to suppression for that first 6 months, because any kind of like tingle, bump, anything they feel down there, they're going to think it's that. So I feel like it not only suppresses the shedding, but it gives them a little bit of, comfort, because they're probably going to be a little anxious. And then as far as when else would you think suppression would be, other than that first 6 months? Can you think of some scenarios where the suppressive therapy would be indicated or encouraged?
Definitely pregnancy. Say you want to start treatment at 36 weeks gestation to prevent any lesions or shedding to protect the infant during delivery, because it can
Yes, it's
be.
definitely, even though, like you said, the testing's not necessarily indicated for pregnancy, but if you have a provider that is testing, which I know you do,
We do.
then the recommendation is at 36 weeks to start suppression. So some other cases would be like if you had a serodiscordant couple. So if one couple or one partner had it and the other one didn't, the partner that had it could take suppression to reduce the risk of giving it to their partner. Some other like treatment regimens could be, typically this virus, if it's going to show itself, it's going to be when your immune system is taxed, right? Whether like pregnancy, whether your body's fighting another cold or another infection. And of course, with the type 1, a lot of times the sun can aggravate and lead to like fever blisters. So I say all that just to mention that you can, that they can do like a treatment if they know they're going to be studying for finals, staying up all night, like their body's going to be taxed. They can do just like some suppression during that time. Patients might opt to do that rather than just doing suppression all the time. Anything else on this slide?
Just like with other STDs, they're more at risk for HIV infection. They want to counsel them on that.
And definitely like if you have patients like men who have sex with men, or you want to make sure if they do have it, then they probably should be on suppression, because you're right, like the presence, like if you've got any lesions or there's any like small little tears in the mucous membranes, then definitely that sets a place up for HIV to enter. And here's some slides, and you can tell that they're painful for sure. Moving on to the human papillomavirus, or HPV. So typically this wouldn't be a painful lesion. Not that you couldn't have a painful lesion. You could if it's in a certain spot that's uncomfortable, but typically HPV condylomas are not painful. If patients complain of any, like they may complain of like itching or something, usually. This is the most common sexually transmitted infection, and HPV is associated with numerous cancers, including, I'm sure you've heard, cervical cancer, but also rectal and oral pharyngeal cancers. And this is why the vaccine is recommended. So what do we want to say? Anything about, you've got differentials. There's numerous strains, and you've got listed here that there's 14 high-risk strains, and that basically just means the oncogenic strains that can cause cancer. And then I mentioned some of the symptoms. It is typically asymptomatic, or HPV is, and the low risk strains are the ones that typically cause the condylomas or warts. And we mentioned the high risk strains are associated with dysplasia and malignancy, like some of the ones you have listed here. So for HPV, there's patient and provider applied treatments for the condylomas. And we won't go into all those, but there are some that are available to do in the office, some to give them to do at home. This is also influenced by one's immune system. So if your immune system's taxed, it's when it might show itself, or when it's slow to resolve. And just to say, the CDC does recommend that all individuals, actually up to 45 years of age, be vaccinated against HPV. But when it first came out, it was just that age group from 9 to 11 to 26. So typically the insurances will only cover people up to 26. Has that been your experience, Olivia?
I haven't had too much experience with it with the older population. We do recommend it to all the younger ones that come into clinic.
And you want to try to catch them before they have sex for the first time ever, because your risk of acquiring, one strain of HPV during your very first sexual encounter is over 80%. So if you can catch them, prior to that. It's also important to note, if you've got a patient who already knows they have HPV. Maybe they had an abnormal pap smear, 5 years ago or something. Would you still recommend the vaccine for that patient?
Yes, because it could protect against other strains.
Yes, but it also, their body can clear that strain, right?
Hmm.
So yes, I would encourage, you could be hitting another strain, or again, their body probably cleared that strain and they could possibly be exposed to it again. And here's some photos, and you can see the condylomas are a little bit, they're kind of either that kind of, it's either the skin color or it's kind of that grayish color. Okay, so with Matt, depending on what we're treating him, right, whether he's got syphilis, herpes, or HPV. So as far as I guess that's point of care testing. Is that what that is? A PSC? Okay. So yeah, you would offer definitely testing for if you've got like the rapid HIV, rapid hepatitis C, any kind of testing for other STDs. Else? And then for this, just kind of talking about the syphilis in particular, you would want them to follow up in 6 months after treatment to look at the titers, and you would definitely want to obtain a pre-treatment titer, so like an RPR of 1 in 32, maybe before you started treatment. 6 months later, you want to check that again, and it should drop fourfold. So it might be 1 in 8 for it to be an effective treatment. If they have HIV, you would want to do that sooner, usually at 3 months. Okay. Moving on to our last one. This is our last one.
Yeah, this one in hepatitis.
Oh, that's right. So HIV, also a sexually transmitted infection. Would you want to tell them about this, a little bit about this one?
Yep. So there's also 2 types of HIV. I wasn't aware of that, but there are. Um, People that are at risk are men who have sex with men, unsafe sexual practices, so multiple partners, not using protection, IV drug use, and vertical transmission, so a mother can pass it on to her infant. Any drug use. So in America, young adults that use drugs such as poppers, which is marijuana, alkyl nitrites, cocaine, and ecstasy, before partaking in sexual activity are at risk, most likely because they're probably not as aware of what they're doing. They're not taking precautions.
So patients who contract HIV can be asymptomatic, or they can have like an onset of any viremia symptoms, like they feel like they have the flu. It could be, they could think they're getting COVID. They could think any of those. So that's usually what you would have. And you have onset of symptoms 2 to 4 weeks, but yeah, they can be asymptomatic. So any night sweats, joint pain, swollen lymph nodes, sore throat. And then on this slide, you have the acute HIV infection, which is if they have any symptoms, it's going to be that viremia. Chronic, and then AIDS. So anything on here that we should say? So they do have rapid testing for HIV that is they're called the most recent is the 4th generation, and they include not only the antibody, because remember the antibody can take up to 3 months to develop, but these 4th generation tests have that P24 antigen, which shows up pretty quickly. And then of course, you can get serology, because you definitely want to get serology to confirm, not make a diagnosis based on a rapid test. Just to say a little bit about the medications, we've definitely come a long way with medications. It used to take, 3 or 4 drugs of the antiretrovirals to keep them suppressed. And when we say that, we're keeping their viral load so low. But now, you're looking at 1, maybe 2 pills now, and you can usually get viral load suppressed pretty quickly if the patient is compliant. And the benefit, if you can get the patient at undetectable viral loads, they can't pass it, right?
Mm-hmm.
You've heard the U equals U, undetectable. Anything else about that? It's important to remember that this, I feel like cancer, this HIV is not a death sentence, right? We have many people living with this chronic condition, and they can live very healthy lives.
All right.
Oh, he does have a swollen lymph node.
Yeah.
Oh, that's a good little chart. And it's important to remember with HIV patients that they might not present typical, with STDs. So they may have way higher titers for like syphilis. It just might not be the typical presentation that you would see in other patients. So the last one is hepatitis. Kind of just go through this real quick. There's several different strains of hepatitis. Remember, with A and E, it's typically transmitted oral fecal route, and those are typically acute infections. B, C, and D are passed through blood and body fluids, and these can develop into the chronic infections if left untreated. There's been some, like the HIV drugs, there's been great advances in the pharmacological treatments of hepatitis C, but note there's still no vaccine available for hepatitis C, but there are vaccines available for hepatitis A and B. And it is recommended that pregnant women be screened for hepatitis B and hepatitis C. And the symptoms are pretty similar across the different hepatitis. So they may be jaundice, have icterus, dark urine, pale stools. So testing is done with antigen and antibody testing. Of course, you can decipher between chronic and acute infection by the presence of IgM and IgG. And then diagnosis can be confirmed with the RNA testing. So we use the rapid HCV, the hepatitis C.
Mm-hmm.
And if you have a patient test positive for that, because I've had a few false positives, then you would obtain the HCV RNA to confirm it, and then refer to GI. And here's some pictures. A little angioma. And that is it. Thank you for joining us, and thank you, Olivia.
Oh, yeah, thank you.
All right. Figure out how to stop it.